my message to you today is about the fact that you as an individual must take responsibility for the patients that you care for. So it doesn't matter what ward you work on, no matter how complex or simple you believe that patient caseload to be, they are all patients and they all come with their own potential risks. And I think that if we go for the idea that pharmacists, being the medicines experts and taking responsibility for what happens to their medicines and their use of medicines when they're in hospital is absolutely key. Having said that, pharmacy can't do it on its own, and I believe that if you have a problem, you have to share and own a problem for it to happen and to be able to overcome it. So although pharmacists are absolutely critical as the health professional leading on medicines safety and medicines management or medicines optimization, whichever word you want to use, if we don't get the nursing and the medical colleagues on board, either at trust level or more importantly your own personal level at the ward level, then we're going to find this more difficult. So I think what I'm trying to say is that use your expertise in medicines to involve the medical and the nursing staff on your ward, so that we try to ensure that the risk of any harm due to medicines is limited on the wards that you work on. And I don't really need to spell this out for you, but if we think about what are the things that we want to focus on, okay, because it will slightly differ between different patients and different wards, but everybody knows medicines reconciliation has actually recently in an international document been shown that it's something that we should all be spending a lot of time on to try to reduce the risk of harm to patients. There's good evidence for that. We must focus on high-risk medicines. So again, if you know anything about safety, we think about anticoagulation, insulin, opiates, chemotherapy. Those are the things that the MPSA and other international organisations tell us that we should concentrate on. So those are the people that we should be looking for. Particularly if you're a junior pharmacist, but do you know what? Even the most senior pharmacist needs to know what their level of competence is. And if they come across a patient and they know instinctively that that person is way outside their comfort zone. So let's say they're an HIV patient who's come in, who's got end-stage renal failure, who's on hemodialysis, who then comes in with liver dysfunction. If you're a Band 6 pharmacist, you just know that that person is not for your caseload. And one of the things that I think pharmacy is getting to terms with now is escalating and saying, it's not appropriate for me to look after this patient. And I would urge you all to feel very, very comfortable about referring patients to somebody more senior in your pharmacy team if you damn well know that that person is outside your competence. So hospitals are trying to design ways to prioritise this so that we can actually say, no, this person is at high pharmaceutical risk, therefore we should try and use our most experienced pharmacists. But as I say, even if it's somebody who's experienced, if you then deal with what turns out to be a complex mental health issue, you may want to escalate and take advice from the mental health pharmacist. And I think that pharmacists for too long have tried to, I must know everything about everything, and actually we've gone wrong there slightly, and we must feel very comfortable to refer, and escalate is the word that they use in the nursing hierarchy. And doctors are very, very keen and happy to do this. So, medicines reconciliation, focus on high-risk medicines, be prepared to escalate if you know that it's outside your competence. But the other thing I would say with my safety hat on is if people don't report what's going wrong and don't give feedback to people, then we're never going to get to the idea of zero harm being a reality. So you must take responsibility for the patient caseload that you look after. In other words, I think if you think of this idea of trying to make zero harm a reality, if you take the attitude, not on my watch, okay, which sounds a little bit archaic and a bit Lord Kitchener and in an armed forces style, but you know, if everybody actually was thinking to themselves, I don't want anybody on my ward to actually come due to harm that was preventable due to high-risk medicines, for example, or if you have a spate of, you know that people are not getting their insulin, for example, then you have within your gift the ability to make something happen there. If you don't think you can do it yourself by feeding back to the medical and nursing staff, then again you go and you escalate, or you just report it, and the reporting system is there to actually ensure that somebody else more senior then goes and actually investigates it. So reporting and giving feedback about things that are going wrong is really, really important. And I think that if you take those 4 things, okay, and you take responsibility for the patients that you're looking after, that is our way of trying to ensure that our patients do not end up being in a Francis report style incident, and that actually we can move towards making zero harm a reality for the patients that come into our organisations.